DeRuin. I'm Executive Associate Dean of the School of Dentistry. However, I'm here this afternoon as a member of the Education Corps of the Institute of Translational Health Sciences to welcome you to another ITHS Interdisciplinary Grand Rounds. The Institute for Translational Health Sciences is an interinstitutional organization with members that include the University of Washington, Seattle Children's, Fred Hutch Cancer Research Center, Group Health Research Institute, and numerous other institutions in the Seattle area and actually throughout the Pacific Northwest. The ITHS is designed to facilitate, encourage, and enhance interdisciplinary clinical and translational research in its member institutions. If you are not already a member of ITHS and wish to find out more about it, please consult the website at www.iths.org, or I think the information you received as a handout for those in the audience should tell you more about it. The ITHS Interdisciplinary Grand Rounds is an effort by the Education Corps to examine prominent, complex, contemporary issues in biomedical research in an interdisciplinary manner with the hope of providing to the scientific and lay communities better understanding of these issues. The issue addressed in the program today is one that's been in the news in the past few days: the relationship of childhood vaccinations and autism, and specifically whether vaccinations put a child at increased risk of developing autism. We're pleased to have an expert panel who can speak with authority on the issue. I will briefly introduce the three speakers now so that we can move quickly from one presentation to another without further introductions. The first speaker will be Dr. Wendy Stone. Dr. Stone is, as of 1 month ago, the new director of the Autism Center at the University of Washington. She's a professor of psychology, and prior to joining UW, she was a member of the Kennedy Center for Research on Human Development at Vanderbilt University. She will give an overview of autism and known risk factors for it, and indicate when and how the controversy over the role of childhood vaccinations in autism developed. The second speaker will be Dr. Albert Berg. Dr. Berg is professor of family medicine and former chair of the U.S. Preventive Services Task Force. He served on the Institute of Medicine committee that examined the relationship between the measles, mumps, rubella vaccine and autism. He will give an overview of the process followed by the committee as well as of its conclusions. The third speaker will be Dr. Charles Cowan, a developmental pediatrician who is clinical professor of pediatrics and psychiatry and director of the Autism Medical Services at Seattle Children's. Dr. Cowan will address the plausibility of the vaccine-autism causal connection. After Dr. Cowan's presentation, Dr. Stone will briefly recap what was presented, and then the panel will join her and take questions. This presentation is being recorded on UW television, and it will be archived and will be accessible through them after today's program. Without further delay then, I would like to turn now to our first presenter, Dr. Wendy Stone.
So I'm happy to be here to give you an overview of autism and a little intro to the vaccine controversy. As many of you probably know, autism is a very complex neurodevelopmental disorder. Neuro because it affects the way the brain develops, developmental because it occurs very early in life and has symptoms that change with time and age and development. The diagnosis for autism is behavioral. We don't have any biological markers, no medical tests that can identify whether or not a child has autism. So we have to rely on a pattern on a symptom profile of behaviors in three areas. One is the way children interact with other people, social impairments that are core to the disorder. Second has to do with language and communication disorders, understanding and being able to use language and the communication that actually precedes language. And then third is a set of limited flexibility in responding to the environment. So restricted activities, restricted interests, and it's this pattern of all three behaviors that comprises autism. What is probably most characteristic and true of all of autism is that the symptoms are extremely heterogeneous. Symptoms can range from mild impairment to severe impairment. They vary from one child to another. They vary within the same child over time, which provides some diagnostic challenges. In terms of the social spectrum, for example, some children are aloof and seem like they really aren't interested in interacting with others. Others are very interested in interacting and having friends, but they have some difficulty doing that because of a lack of understanding and insight into other people, and that social give and take, which is core to developing friendships. In the communication spectrum, another example is that there's a child who may have very limited ways to communicate, hasn't actually figured out the process of communication, that there is a way to get one's needs known or met through another person. So that's at one level, and maybe just knows to take a hand without paying attention to the face and making eye contact, or using facial expressions to convey the need. At the other end of the spectrum are individuals who have conversational language. Their grammatical structures and syntax are fine, but what makes it difficult for them in terms of communication is not understanding the perspective of other people and not choosing topics that other people might be interested in, and the one-sided nature of the interaction and communication. Restricted activities and interests can take many different forms. At one level, there are children who are very interested in the sensory aspects of objects, may like to hold things up and inspect them visually. There are other children who have repetitive motor mannerisms. And then we have children who have more elaborate rituals or routines, and this child in the bottom is exploring train timetables in all of Europe. Interests that are very circumscribed, very focused, and then very specific ways of doing things. So those are the characteristics. The prevalence, as I'm sure you all know, has increased dramatically in the past 15 years. And now, according to the CDC report in 2009, the prevalence is about 1 in 110 children, and autism is more common in boys, so the number is 1 in 70 boys. Now, this prevalence, these numbers have increased over 20 times from when I started in this field. It used to be 3 to 4 per 10,000. So this is really a dramatic, remarkable increase. And there are lots of potential reasons. I don't think that anybody's solved the question of why the increase is so dramatic, but certainly with more people aware of autism and aware of it as a diagnosis, it's much easier to use that diagnostic category. And then what sometimes happens is that people use the category of autism instead of another developmental disorder, so it's diagnostic substitution. We also have the situation in which the diagnostic criteria for the disorder have changed and become more liberal, so that children with milder degrees of impairments are now included in the category. And we're also identifying children at younger ages, so we're adding more children to that pool. But nobody's clear on whether the actual numbers have increased or the numbers of children with the diagnosis have increased, but it certainly seems like it's both to me. Not only do children with autism have this constellation of behavioral features, but there are also associated conditions that are common. Intellectual disability occurs in some children. Some have genetic or metabolic disorders. About a quarter to a third have some form of seizure disorder. Sleep difficulties are fairly common, occurring in about half. GI symptoms are also reportedly common. And then in older and more able individuals, that we sometimes see mental health symptoms such as anxiety and depression. Unfortunately, we don't know the cause for autism, and the idea now is that there probably isn't going to be a cause for autism. There's a saying in the field that if you know one child with autism, you know one child with autism. And autism is often referred to as the autisms because it's very unlikely there's going to be one single cause for this heterogeneous disorder. We do know that there's a strong genetic component. I know Chuck's going to talk a little bit more about that, but I will say that the risk to subsequent siblings is elevated if there's one child in the family. Among families, there are related symptoms that are not at clinical levels, but family members who may not like to interact, may be very shy socially, and have less severe forms or very mild forms of some of these characteristics. But the sense is that the cause is multifactorial. It's going to be a combination of genetic vulnerability and environmental influences. And what those environmental influences are is not quite known yet either. But certainly when we think of the general overall risk factors for autism, genetics is way up there. We know a family history of autism will create a vulnerability in a child. There are also spontaneous genetic variations that have been identified, copy number variants. Gender is a risk factor. Autism is more common in males by 3 or 4 to 1. Perinatal complications such as have birth by C-section or low birth weight or prematurity, and older parental age. Different findings have reported that this for mothers and for fathers. With advanced age, there's a higher risk of autism. But I want to emphasize that these are all correlates. They are not causes. We don't know what causes it. And the fact that some of these conditions are present does not correspond in a one-on-one way to having autism. I'm mentioning the onset and diagnosis because I think it's particularly important when we think about the vaccines and the timing of things. So by definition, the diagnosis of autism requires that behavioral symptoms appear by the age of 36 months. It's interesting that parents, just for as long as this has been reported, parents typically report concerns about their child's development at about 17 or 18 months. And the average age of diagnosis still is not until about 3 or 4. That's in this country. We can make the diagnosis at 18 to 24 months, but it tends to be more stable when it's made later at 30 to 36 months. It used to be thought that there were 2 different onset patterns, and Sally Ozanoff actually has done a great job of reviewing the literature and some of her own work that has changed how we're thinking about the onset. It used to be thought that one pattern was that children had autism and had characteristics of autism from birth. There were reports of children who would arch their backs when they were held, who wouldn't look at faces. And then there was another kind of onset that was recorded, which was typical development over the first year of life, but then some sort of regression in the second year. And after reviewing the literature and subsequent work, it's come to light that it isn't necessarily the case that the children who were thought to have typical development before the regression actually did have typical development. There were often some delays there. So that's another pattern. And then the fourth is it isn't necessarily the case that the children with typical development actually regressed, but it looked more like for a subgroup, there was more of a plateau. It wasn't that they lost skills, it was that their skills didn't develop commensurate with their age. But the current consensus is that the symptoms develop gradually over the first 18 months. Since there's no cause known, there's no cure known either, and the treatment focus is on symptom improvement. There are some treatment approaches that are used. Early intervention seems to be highly effective in reducing symptoms, improving all aspects of behavior. Specialized behavioral and educational methods are necessary. Children with autism don't respond as well to generic forms of intervention, but there are forms that are specialized to their unique needs. They kind of have a triple whammy in terms of learning, because they aren't necessarily going to be rewarded by social input, which is why young children learn. They do the things that you want them to do, not because it's fun for them sometimes, but because they want to please their parent. So if there isn't that motivation, that's kind of one damper. Not understanding the communication or being able to communicate their own needs in an effective way, and then also having to have things be the exact same way all present challenges in a learning environment. Medication is used sometimes as an adjunct for comorbid conditions. Again, it's not a cure, but it can be useful for reducing irritability, anxiety, signs, attention deficits, seizures. In this population, the use of complementary and alternative medications and treatments is the norm. And that's another thing that's important to consider. There, again, without a known cause or cure, parents are very interested in doing whatever they can for their children, and that is certainly understandable. So how did we get to this point of the vaccine controversy? This is only one example of a billboard. If you go on the internet, you can find lots of very extreme comments reflecting very strong feelings. But it seems that there was a convergence of events that kind of led to this perfect storm. So it started, and I'll just go over this briefly because I know others are going to discuss this, in 1998 when there was a publication that suggested that the MMR vaccine was linked to GI disease as well as behavioral regression. A year later, and totally on a parallel track, the CDC and the American Academy of Pediatrics recommended removing thimerosal from all vaccines due to thimerosal and due to concerns about mercury. And then they issued a not-so-comforting press release that was, the current levels of thimerosal will not hurt children, but reducing those levels will make safe vaccines even safer. So that's kind of hard to, it's hard to fit those two parts of the sentence together. And then in 2000, the CDC, the Center for Disease Control and Prevention, did a prevalence study in Brick Township, New Jersey, and found the highest rates that have ever been reported in the U.S., which was 4 to 6 per 1,000. And it turns out that these prevalence rates had been reported elsewhere, and that these subsequently were replicated in other parts of the country. So how did we get here? First of all, we have the complications or the features of this complicated disorder, autism. There's no known cause, there's no known cure. When there's no cure, people are looking for something. When there's no known cause, people are looking for something. We want to know why we woke up with a stuffed nose. I mean, we're always looking for causes. Second, the symptoms are observed at about 18 months. And third, one of the onset patterns includes regression. Okay, so that's just the background autism part. Then in the news, we have these new reports of increases in autism prevalence and concerns about vaccine safety. And that, combined with this temporal proximity between symptoms and vaccines, so the time at which the vaccines are administered is about the time that the symptoms happened to show up in autism. So putting that together, it was the perfect storm for imputing a causal relation between the two. So I am going to introduce Dr. Berg now.
So the perfect storm started for the Institute of Medicine Committee at the first meeting. Congressman Burton showed up. He was one of the first folks testifying, and his grandson, just a few months before, had gone to the pediatrician in the morning, perfectly normal, and came home autistic after getting an MMR vaccine. And of course, the proximity of the vaccine to the onset of symptoms was exactly the kind of issue that Dr. Stone just presented. That precipitated this controversy in about 1998, 1999. So the Institute of Medicine was commissioned by the CDC and the NIH to provide a number of reports on the question of vaccines and vaccine safety, not only on the possible connection between vaccines and autism, but between vaccines and other adverse events. The Institute of Medicine is one of the national academies. The national academies were chartered during the Lincoln administration. They're not federally funded directly. That is, they don't get any appropriation from Congress, but Congress will often direct federal agencies to contract with the national academies to conduct scientific reviews of various issues. And there are three academies. There's the Institute of Medicine, the National Academy of Sciences, and the National Academy of Engineering. And you often see reports in the media on environmental issues, on occupational issues, on a whole variety of things that are done by the national academies. So the Institute of Medicine was commissioned to do a series of reports looking at the safety of vaccines. And we produced three reports having to do with the autism controversy. The first on MMR and autism in 2001, the second on thimerosal containing vaccines and neurodevelopmental disorders, which of course included autism, and then a few years later a reprise on the topic of vaccines and autism, looking not only at MMR and others and also looking at some of the more recent data. The committee produced 9 reports over 3 years. There were 15 members of the committee that represented a broad spectrum of expertise. And of course, the committee members were supplemented by many consultants and experts from government, from academia, and industry. And as I mentioned, these reports were supported by the CDC and NIH. At the time, the CDC in particular was under fire because they were perceived to be in bed with the vaccine manufacturers and not able to make a completely objective assessment. So the process for these reports was the same for each of the 9 reports. It began with a systematic literature review. Systematic literature reviews is a technology that is increasingly common as sort of an international consensus on how to do a systematic review, being very explicit about an analytic framework, key questions, and how you address the questions. Then there was a public meeting, which included presentations from experts and also invited other interested parties, including some of the folks putting together the websites that Dr. Stone alluded to. And then there was a considerable period for public comment, in some cases several hours. Also, fairly new to the process, and remember this was almost 10 years ago, was a public website on which folks could post things and comment. The reports then reached findings, conclusions, and made recommendations, and at the end each report is subjected to quite rigorous peer review. For each of the reports, there were 3 basic components. There's a plausibility assessment, that is, for the supposed relationship between a vaccine and an adverse outcome, what is the likelihood that that's a causal relationship? And there were 7 different types of conclusions that could be reached, all the way from it's clearly related to it's clearly not related, with shades of gray in between. The second part of it was the significance. If there was or was not a relationship, how big a deal is this? In some cases, vaccine side effects might be quite mild, related to just a few hours after the vaccine. In other cases, vaccine adverse effects can be lifelong and permanent. So how big a deal is the adverse event? And then finally, a series of recommendations. How should the public health respond? Should there be a difference in public policy on use of the vaccines? What are the research priorities, and how should all this be communicated? So this is just a cover shot of one of the reports. This is the one on measles, mumps, rubella vaccines and autism. And these, of course, are all available on the web. It's just iom.edu. You can go and get the PDF on any of these reports. So the first report was on MMR and autism. And the evidence favored rejection of a causal relationship. And I'll just pause here to comment on the evidence. I'm kind of I'm a card-carrying member of the evidence police, and the evidence is terrible. It's case reports like Congressman Burton. It's sometimes case series. There's something called the Vaccine Adverse Event Reporting System, VAERS. If you're a pediatrician or a family doctor or nurse practitioner and you give a child a vaccine and something happens and you think there may be a relationship. You don't know, but you think there may be a relationship. You're asked to fill out a VAERS report. Well, first of all, you can see the difficulty from an epidemiologist's point of view. How many potential adverse events are even recognized by the provider, how many of them are reported, and how many are correctly reported. And so you look at those VAERS reports and you wonder what it all means. We actually looked at every single VAERS report over a considerable interval alleging a relationship between MMR and autism, for example. But that's just the tip of the iceberg with the evidence. The evidence is uniformly of very poor quality. You have case reports, you have case series. The best quality evidence is probably the ecological studies that are sort of natural experiments where vaccines have been rolled into place over a period of time within a population, and you could get some sense as the vaccine penetrates the population what happens with an adverse event. Or in the case of some European countries, a vaccine would be implemented in Sweden, but not next door in Norway until 2 years later, and you have a chance to see whether there's a differential development of a potential adverse effect. So the quality evidence was really quite unsatisfactory, but the committee ended up favoring rejection of a causal relationship. But this is really at the population level. There's no way that these large epidemiological studies can completely rule out the possibility of a relationship in a small number of children who may have some unusual characteristic that we don't know about. The committee recommended no change in vaccine policy, but had quite an extensive research agenda, most of which I would have to say has been not implemented. One of the questions in autism, of course, as Dr. Stone alluded to, is the changing definition of autism. And recall this review happened almost 10 years ago. At that time, there were almost never any two epidemiologic studies that defined autism in quite the same way. Made it very, very, very difficult to look across studies for potential similarities and dissimilarities. We made a number of specific recommendations on the kinds of studies that would further inform the debate, and made a strong recommendation for better surveillance so that we're not at the mercy of this quite ad hoc approach to reporting adverse events that we had at the time. One of the other potential causes for autism that was alleged was thimerosal, which is a mercury-containing preservative in a number of vaccines at the time. Again, using a very similar process, we concluded that the hypothesis was not established, but it was biologically plausible. We heard plenty of evidence about what mercury can do to biologic systems, and even though there was no direct evidence about the kind of mercury that occurred in thimerosal, there was enough evidence from other sources to raise the question whether there could be a relationship. But of course, any scientist worth his or her salt can come up with lots of plausible explanations for things. That's kind of what we do for a living. So the fact that there is a potential plausible relationship between thimerosal and autism does not mean that it's by any means a proven or even a likely relationship. Because the evidence was so inadequate, we couldn't accept or reject a causal relationship. We recommended no change in policy. Recall at the time the CDC and the AAP had already said that let's take thimerosal out of vaccines, so the committee simply agreed. We did go one step further. Well, if you're going to do that, you might as well take the vaccines off the shelf that still have thimerosal in them and toss them. That made a lot of people very unhappy, but it seemed to us the only logical conclusion to the policy that had already been established. And again, we commented on the need for basic and epidemiologic research. And finally, there were several more studies done over the next few years, and we did another report in 2004 that took a somewhat more comprehensive view and took into account some of the larger ecological studies that had come out of Europe, and again concluded that the evidence favored a rejection of a causal relationship with either MMR or thimerosal. And I wanted to conclude with just one slide. My personal response to all this, first of all, as I've mentioned, I was appalled at the quality of the evidence that we have on vaccine safety. And one had to almost agree with some of the vaccine skeptics about the lack of attention to vaccine surveillance that I think is still a problem in this country. A second issue was what I can only call fraudulent research, and Dr. Cowan will talk about this in a bit, but Dr. Wakefield, who was one of the people who started this in 1998, the saga has unfolded over the last 12 years and is still current just a few weeks ago. But his research, which caused a lot of the concern, was probably fraudulent. But this was by no means all of the research that we saw that was fraudulent. We saw papers where the data were clearly cooked up, showing R-squares of 0.99 on things that probably were related at chance. We saw plots and graphs from attorneys of parents of children who were attempting to get compensation that were clearly fabricated research. Conflict of interest was huge. We heard testimony from a number of individuals who clearly had a huge financial interest at stake if a causal relationship between vaccines and autism could be established in attorneys' fees and other ways of payment. We kept coming back to the unfortunate conclusion that if you followed the money with a given speaker, you could probably figure out why they were alleging what they were alleging. Abusive parents. We had parents bringing their children to these national conferences saying, just look at Johnny. He's pathetic. I mean, using words like that in the presence of the child, and these are kids who are mostly now 7 or 8, being described by their parents in this way in a public forum made you want to call CPS and made you ask the question about what it was parents were thinking to subject their children to this kind of abuse. There was personal threat to committee members. We received death threats. One of the committee members resigned in consequence. One of the meetings was held, I didn't even know what hotel I was going to be going to in Washington, and we all stayed at different hotels and were collected in the morning by unmarked limousines and taken to the food entrance to the Institute of Medicine through security so that we wouldn't be subjected to all the people who were protesting and trying to get into the meeting. It was a very, very threatening environment. And finally, I would have to say that I still remain very skeptical about the quality of vaccine surveillance that we have in this country, which is still unsystematic and which still could miss significant adverse effects of vaccines because we simply don't have the high-quality epidemiologic system to observe it. And the final slide is just something about the National Vaccine Injury Compensation Program. This is a program set up a number of years ago which takes the manufacturers off the hook if there are adverse effects to vaccines. It's funded by a 75-cent per dose tax. If your child has an adverse effect to a vaccine and it's on the approved list, there's no litigation that's necessary. There's documentation's required, but you're entitled to compensation. There's no limit to the reimbursed the unreimbursed expenses. So if your insurance doesn't cover it and you've got lots of expenses beyond it, this program has no limit on the amount of expenses you can claim. The average award is $850,000, and this is several years old, so it wouldn't surprise me if it was beyond that. Adverse events not on the approved list need to be litigated through a special master at the U.S. Court of Federal Claims, and this was part of the focus of these autism hearings, in that parents wanted desperately to have autism put on this list of known adverse effects due to vaccines, which would then permit them to be reimbursed for all kinds of expenses, not only medical expenses, but educational expenses and other things. So this, again, is one of the things that has been bedeviling this entire field for the last 10 years. Very recently, most of the large cases and some of the consolidated cases have been rejected by the special master, based partly on reports such as Institute of Medicine, but also on some of the research that's followed. So at the moment, autism is not on the approved list of compensable injuries due to vaccines. And the final slide is just where you can find any Institute of Medicine report, iom.edu. Thanks.
My task is to try to review all of the evidence in 15 minutes that there is no association between autism and vaccines. So we're going to have to fly through a lot of slides. So I think the first question that we should ask is, why should we even consider an environmental factor for autism? One of the things that we know very clearly is that autism is a highly genetic disorder. We know this on the basis of twin studies that show that monozygotic or identical twins have a very high correlation of similarity in terms of autism. And when you compare those to fraternal twins, to non-identical twins, it's much lower. And that evidence has been available for very many years. So if autism is caused by genes, then it's reasonable that all identical twins should be similarly affected. And so that brings up the question, why is there some discrepancy in terms of the severity or even existence of autism in identical twins? That's what raises the question of, is there another factor to consider beside a genetic etiology? So that's produced what has been commonly called a second hit hypothesis. And this hypothesis is true for a lot of human disorders. It defines that there is a genetic risk that may exist, and then something else happens in the life of that individual. Diabetes, an example, development of obesity will contribute to the onset of diabetes. Air quality and asthma, many, many factors. And so this is a common human phenomena. So if that's true, if there is an environmental factor, then looking at these curves, this is an aggregate series of epidemiologic studies dating back to 1966. What Wendy's mentioned and what Al has mentioned is that we can see that there has been an enormous increase in the prevalence of autism. Most recent study is the CDC study in 2009, where the autism rate is at about 1% of the population. And so if we have a genetic disorder, and genes in the community do not change rapidly, do not change overnight, one can presume, perhaps, that there is an environmental factor, something that's happened in the last 15 years to the entire world's population that interacts with a genetic risk, then suddenly you have a lot more. The big question is can this phenomena be explained by other issues? So this is another graph from the California data set that shows a similar rise. But what I wanted to point out with this slide versus other slides is that the rate of identified cases continues to be less than what the true prevalence in the community is. We're catching up to that true prevalence. And that catch-up can account for a lot of the increase in prevalence. So you've heard this from other speakers. Nobody knows what the true prevalence of autism is. I suspect from recent and other studies, and there are studies that go back to the early part of this decade that said that the prevalence is at about 1%. There were some British studies done in 2001 and 2002 that predicted a prevalence of 1%. So that raises the question, has this disorder really increased, implying an environmental cause or not? Many, many environmental risk factors have been proposed. The earliest one in the 50s was that this was a consequence of the way you raise children. It's clearly been disproven. As Wendy mentioned, obstetric practices, vaccines, toxic chemicals, heavy metals, and many, many more have been proposed as environmental factors that interact with the genetic risk. So how would we go about trying to figure this out? Well, as Al mentioned, there's scientific plausibility. Is there an actual mechanism that could explain that? For example, when AIDS was first described as a clinical disorder in the early 80s, we discovered a virus. It all fit together. It's biologically and clinically plausible. Epidemiologic studies help us to figure out if there's a relationship. For instance, in my career, sudden infant death syndrome was apparently associated with sleep position. No one would have suspected that. We discovered that through big epidemiologic studies. And in fact, when sleep position practices in the United States were changed, the prevalence of sudden infant death syndrome dramatically decreased. So sometimes vaccines have actually known to cause neurologic problems. A couple of specific examples. There was a fairly dramatic case reported in 2006 by Andrew Zimmerman and colleagues about a young girl who received a vaccination, developed what looked like autism, and in fact this is the case that actually the vaccine court acknowledged as a specific disorder that got compensated. And it was discovered that the reason this happened was that she had a very rare condition, a mitochondrial disorder, that in conjunction with the vaccine could have caused autism. There is still a lot of controversy around this one specific case, but nevertheless the vaccine court acknowledged that this is a possibility. And then for years, there were allegations that diphtheria pertussis tetanus vaccine, DPT vaccine, caused neurologic injury. And in fact, a recent retrospective review discovered that some very rare disorders, these genetic disorders that cause a problem in a sodium channel gene that produces seizures, have clearly been associated with the onset of autism following a vaccine. And in fact, we had a case like that at Seattle Children's about a year and a half ago. So very rare conditions. It is plausible that in certain very unique circumstances, a vaccine could cause a problem and produce a neurologic disorder that sort of looks like autism. But most vaccine associations have not been demonstrated, as Al mentioned. It's hard to go over the Andrew Wakefield story again and again, so I'm going to kind of skip through some of these slides, only to say that the British General Medical Council has taken away Dr. Wakefield's privileges to practice medicine in the United Kingdom. By the way, he came to the United States, set up, was part of an organization in Texas. He subsequently resigned from that organization. He was not allowed to practice medicine in the United States. And there have been many, many studies that have shown both epidemiologically and biologically plausible that there is no relationship. Among others, that no one has yet to demonstrate what Wakefield's group claimed to find evidence of measles virus in intestinal tissue. Those studies have been replicated, and no one's been able to demonstrate what Wakefield claimed. We also have some epidemiologic studies, and in fact, what was rather interesting to me was that I was reading one of the websites from an organization that purports to support Andrew Wakefield, and they listed a series of articles that purported to support his allegations. And actually, if you looked at those articles, they said just the opposite. So unfortunately, we do live in this internet world in which, like the old game of telephone where somebody says something to somebody, it says something to the next person, information gets very distorted in that reality. So here was a very nice study that was done in Montreal, and it's a complicated slide, but basically what this slide showed was that as the rate of MMR vaccination over time declined, the rate of autism increased. So just the opposite of I mean, that's, if MMR is a cause of autism, you would expect the opposite to be occurring. Thimerosal came about in 2001. A woman named Sally Bernard wrote an article for the journal Medical Hypothesis in which she basically looked at the symptoms of autism, the symptoms of mercury poisoning, and said, see, they fit. No research, no medical plausibility. And so these kind of graphs appeared on the internet that showed a direct correlation between the level of mercury exposure and the degree of autism. I actually could draw the same graph for autism and the prevalence of cell phone use. So what is thimerosal? It's a mercury compound. It's a mercury compound. It has been shown to deposit in the brain. There have been studies at the University of Washington that demonstrate that. But there is yet no biologic evidence of a correlation clinically or epidemiologically between thimerosal and autism. And I just want to point out the last point on this slide, urine excretion. So in the alternative world, what happens is that you're given a dose of a chelating agent that causes mercury to be released into your urine, and it's in high levels because, frankly, we all have mercury in our bodies the same way that we all have lead and many other chemicals. What is not available is any kind of control data about what the level of mercury in all children is if you give them one of these chelating agents. So the fact that you get a report back from a laboratory that says your mercury level is very high in your urine, therefore you need to get chelated, has really no basis because there are no controls. And I think we'll, in the face of time, I'm going to skip through a couple slides about more evidence of the lack of correlation between thimerosal, except to say that this study was just published a few days ago, and it's a very interesting study. So it was a very large study. There were over 1,000 children, and these are children who were born between 1993 and 97. That was an era when everybody was getting thimerosal-containing vaccine, and these children were followed 7 to 10 years later, long enough later that if there had been a neurologic problem or autism, it would have been very apparent. And what was interesting was that those children who received vaccines on time in the first 7 months of life had actually better scores on a very broad range of developmental tests than those that did not. So again, very strong evidence that thimerosal has not caused developmental problems as we've studied it at a distance. So lastly, I just want to point out that thimerosal was removed in 2001, and the prevalence of autism has risen. So I think that that's another bit of important information as to why this relationship doesn't actually make any scientific sense. So Wendy's going to wrap up from here, and then we'll have, I hope, a couple minutes for questions.
So I'm not going to wrap up with any answers. Let me warn you about that. So we are in the midst of this controversy. The public is well educated. People who are proponents of or against vaccines are not uneducated people. It sounds trite to say that somehow we have to improve communication and understanding and trust between the scientific community and and the community that are anti-vaccines. I think as scientists, we don't always do a good job of translating information and educating the public in terms of what things mean. So I think some PR could be in order. And certainly we need to continue to explore the role of environmental factors in the development of autism as well as other disorders. One of the ways that we're getting at this is the National Children's Study, which is a study of 100,000 children across the U.S. in 105 sites, Seattle being one of them, that is looking for environmental causes of childhood disease and disorder. And it's a very, very intricate, expensive study, and but I think it's one of the ways we can try to understand this more. These are in planning for this study. This was a list of potential chemicals that were considered for study in the National Children's Study. And just to give you a sense, I know you can't read them, but this is how many there were in a page. And here's mercury. Mercury is one. So mercury is one of very many possibilities. And I think that as scientists, we need to explore what some of the others are.
How does the child's body know to only form antibodies to the virus and not the other ingredients?
If it's a big enough protein, your body does form antibodies. There's no question about that.
One of the questions one of the other committees looked at was this question of, we've got so many more vaccines, maybe just the sheer volume of antigens is causing trouble with children. But actually the evidence is that children are exposed to probably 30 or 40,000 antigens in the first few years of life, and whether you're looking at 5 or 10 or 15 or 20 components of a vaccine, it's a very, very small percentage of the total things that a child is exposed to. So we didn't find that argument compelling. We thought that the evidence probably supported that that potential mechanism was not operating.
What kind of data would you like to see on vaccine safety that currently we don't have?
Just briefly, the problem is we don't have a good surveillance mechanism once vaccines have been released. This is a problem also with drug safety, is that we don't have a way to make sure that once a drug is approved and 100,000 people are taking it, that everyone is providing data to find out whether there are adverse events. We don't have it for vaccines either. So we're pretty much at the mercy of individual parents or pediatricians or nurses or whoever to make a connection and allege a connection and then have someone try to figure it out. But we don't do it systematically. And we need to do a lot of it because some of these reactions, even the ones on the official list, happen 1 in 10,000 or 1 in 100,000. We need very large surveillance systems to be able to pick up that kind of stuff, and we just don't have them. No one's supporting that kind of work.
So the vaccine safety data link that's run by the CDC is not big enough?
Not big enough.
In your opinion?
Thank you.
I think this question is for Dr. Stone, but it can be for any of you. The point was raised that one of the phenomena we're seeing is that we're still dealing with the possibility that autism is still underreported or not diagnosed correctly or whatever. And also we heard the point that that even after thimerosal was removed from vaccines, autism rates continue to rise. So this sort of suggests the question, at what point are we confident enough in the accuracy and the comprehensiveness of the reporting of autism where we can say that we have a good knowledge of the landscape against which we're setting these epidemiological studies?
That's a great question, and I do not have an answer. There's a new set of diagnostic criteria coming out in 2013, so that will change things again. It's hard to, I mean, it's hard. Different clinicians disagree about the same child. So at that level, it's difficult. And then at the bigger level, when you're having to do an epidemiological study and don't have the luxury of doing comprehensive diagnostic evaluations for each child, that's complicated as well. So that's a good question until there's a biological test.
But I would argue that that's the same for a lot of human conditions. So it's true for cancer, where we're diagnosing things at earlier and earlier ages, at earlier stages, before we understand what the biologic potential of that cancer is. So I don't think it's unique to autism. Autism is challenged because we don't have as good measurement system. We can't look under a microscope to define it. So that is a significant problem. I would also say there was just a very recent report that came out of the National Health Service in Britain. It was a very interesting study. It has yet to be published, so it hasn't been put up for scientific scrutiny. But it was a study of the prevalence of autism in adults. So these were adults living in the community all over the United Kingdom. It's a very large study, and they came up with a prevalence rate of 1% using current levels. So that kind of argues against the fact that there is really an autism epidemic, that this is happening to children, if in fact the adults in their 40s have prevalence rates of 1%. And that argues, we'll have to see if that study is replicated, but there is some evidence that perhaps this has been here a lot longer than we recognize, and now we're just defining it differently.
I think because of time limitations, that will be the last question. I'd like to thank the speakers for their excellent presentations.